Good morning, everyone. Louise has been called away last minute, so I'm here instead. I'm Jude, and I'm Louise's colleague. I also work at Healthwatch Halton. So today we are joined by Northwest Ambulance Service. We've got Deborah Gallagher and Jenna Matthews, and they're going to give us a presentation on the services run by the ambulance service, and also their patient panel. And if you've got any questions, you can pop them in the chat or raise your hand at the end, and there'll be time for questions and answers. We're going to put everyone on mute if you're not already. But like I say, any questions or anything, just pop them in the chat. So I'll hand over to Deborah and Jenna. Thank you.
Hi everyone, thanks for having us today. So as Jude just said, we are from Northwest Ambulance Service. Jenna and I both work within the patient engagement team, though we do slightly different roles. I am a patient engagement officer, and Jenna actually looks after our patient and public panel. So between us today, we'll both be doing the presentation, and I will start to share that now. Just to say, neither Jenna or I are clinical. I started with the ambulance service quite a long time ago. Within the patient transport service. So my background's patient transport. I used to plan and control for the patient transport office, and Jenna joined us from some CCG engagement work and what have you quite recently. So we won't be able to answer clinical questions. We will try our best to answer all your questions. If there is anything we can't answer, we'll take it back and find it out for you. So just to say, yeah, we're not clinical, but hopefully we'll still be able to share some things around the ambulance service with you today. So I'm just going to share my presentation. Hopefully that will all work. Let me just share that. So can everyone see that okay? Jenna, can you see it okay? Yeah, good. I've got some nods. I like Zoom for this because I can still see everyone as well. I hate it on Teams when you can't see people as much. So let me just move that on. So yeah, as mentioned, hello. Jenna, do you want to say hi? I've kind of introduced you already, sorry.
Oh yeah, you're throwing it. No, hi everyone. Thanks for having us. So I used to work at St Helens CCG, so not far from Halton really, is it? Just across the way. So yeah, relevant experience with clinical commissioning groups, worked with Healthwatch quite a lot when I worked at St Helens, obviously Healthwatch St Helens, but joined the panel 2 years ago, nearly in September now, so it's come around quite quick. I think the pandemic's kind of sped that up a little bit for me. But no, I lead on the patient and public panel, and I'm going to be talking a little bit about it within the presentation, so I'll not spoil it too soon now, but I'll pass you back over to Debs. But thanks for having us.
Thank you, Jenna. Okay, so these are our core services, and nearly everyone will recognise the urgent and emergency care service. They understand that that's the one you see with blue lights and sirens, and they're the ambulances that will, our emergency ambulances. So I think that's quite clear to everyone that we are responsible for that. We also have our patient transport service that runs. Now, unfortunately, the Halton area is a bit of a strange one because we don't have the contract for Cheshire postcodes. However, there will be some Warrington postcodes that might just fall over the border and what have you. It's a bit of a funny one where you are, but we don't have the Cheshire contract. West Midlands actually have that for the patient transport service. But we do have patient transport contracts in Merseyside, Manchester, Lancs and Cumbria. So yeah, it's a bit of a funny one, but we, like I say, where it's a Cheshire postcode, we don't. Where it's a Mersey postcode, it would be us. So a bit of a strange one there. Resilience. These are our heart teams. Now you may have seen these teams, and especially since in relation to some of the sort of more major incidents we've had going on. So we have 2 heart teams within our service, and HEART stands for Hazardous Area Response Team. And these teams are made up of paramedics, but they have enhanced training skills. So things like, as you can see there, he's in climbing gear. So they have sort of enclosed spaces training, They're able to do sort of things like decontamination. They have a lot of enhanced skills, and where there's major incidents where we might require that additional sort of skills, they'll be called things like Bosley Mill, for instance, when sort of that class, but also just things like, you know, sort of pile ups on the motorway where they might need extrication. So they might just need those enhanced skills. Quite often they're called things like where sort of they might need more of a presence. I know quite often they've been called where sort of people have been on the roofs throwing things and things like that, but yet they have some enhanced skills. And one's based in Liverpool, and one of our teams is based in Manchester. So yeah. And then the other thing that we are also responsible for, and not everyone is aware, is we're responsible for NHS 111 as a service as well. And I will talk about that a little bit more as we go through the presentation, because that's vitally important to us at the moment, and especially during the pandemic. So there are 4 key areas that we work within. To start our response to COVID, like everyone, we've changed so much over the last 18 months now. All our engagements gone online, which was a bit of a change for us. But we've had an established 24/7 command and control structure since March, since the pandemic began. And also we've used our incident response plan in line with quite a few of the other plans that we have in line. So our pandemic influenza plan, our REAP plan, and our demand management plan. Now, our REAP plan is really interesting, and you might have seen this in the news. There's been a few articles recently. I think Manchester Evening News ran one last night about how busy we are and how we're staying on demand. Our REAP plan is our resource escalation action plan, and we run at different levels. So we're always running at a certain level of that plan. And at the moment, we're running at REAP level 4, which is one of our busiest stages that we can be at. Just to say, for instance, the last week of May was our busiest week in 2 years. So we are really at the moment quite busy. So at the moment, level 4, that would mean things like perhaps unnecessary training, any mandatory training that's unnecessary at the moment that can be postponed would be. If there's staff, for instance, that are clinically trained but are currently doing other roles, they would be asked to come out and be clinical staff. And things like overtime, they would be closely looked at to make sure we've got as many resources as we can. Just to say, it's something that's reflected around the country at the moment. It's not just us. I've seen West Midlands today on their Twitter putting out how busy they've been in the last sort of week or so. So it is actually something that's reflected nationally. And interestingly, obviously, you know, we've got a mix of things going on at the moment. We've still got some COVID sort of cases and what have you. And but obviously also sort of people returning back to normality and what have you. So we are quite busy at the moment. So some of our priorities during COVID have been increasing our capacity for the 999 and NHS 111 call handling. This again, I've mentioned the importance of 111. It's been particularly important around NHS 111. They were the first point of contact at the beginning of the pandemic, and now with sort of schemes that my next slide's on, which is NHS 111 first, it's about having built in the capacity there for that call handling. We've increased our PES fleet. We've made sure that we have more vehicles out on the road than we ever have had, ensuring that all our staff have the right PPE and equipment, which will be continuing. Staff and volunteer welfare, we have welfare vehicles that have been out supporting the staff, which is still out at the moment. They can get a cup of tea, they can get something to eat, they can get sort of water when it's really hot, because obviously, as you may be aware, PPE in this kind of heat, as we're expecting this week, is particularly hot. So we have volunteers manning those vans. We also obviously have lots of welfare in terms of support for mental health and what have you throughout the pandemic. We've also increased our critical care transport and coordination there. One of the things we did do around increasing that is some of our PCS colleagues at the beginning of the pandemic were retrained and given enhanced skills and have been supporting our PES staff. So although they perhaps won't go to some of the more critical cases, they're able to sort of help transport and do some of the lower acuity cases. Throughout the pandemic, we'd also had extra support you may have seen from the Army. They supported us for a month-long basis. Again, perhaps acting similar in terms of that PCS support, that they were perhaps not going to the more serious cases, but could help support at some of the lower acuity and the driving and what have you. There has also been some partnership with the fire service as well, that there's been some training around that. We've not actually used them or utilised them in any way, but that training's kind of happened in the background, and perhaps should the situation arise going forward that we might need some additional support, then we may have some going forward. Planning for longer term, because obviously for us, as I've already mentioned, we're still really busy, can't see that changing at the moment, but also that shift back towards perhaps a newer normal. So we're looking at our resourcing. We'll already be doing our winter plans if they're not already done. So we're already looking ahead to that. But as some people will say, actually at the moment, our summer's feeling like winter. So even more so. And the rollout of the vaccine to our staff, this has been a really important one. So we have, I think it's over 5,400 of our staff now vaccinated. So what actually happened with this was there was a central hub set up at our Broughton site, which is Preston, where one of our headquarters is. And they ran for about a month solidly vaccinating staff, and then again during the second phase. But we also have lots of partnerships with local sites, local hospitals, so staff that didn't particularly live close to Broughton or couldn't take that time could go to somewhere local for them to get their vaccines. I was able to get mine at the Countess of Chester through that partnership work, so that was really good as well. And I know we've also had staff supporting that vaccine rollout and giving vaccines at certain sites as well. And I think the comms plan's in there because we obviously sit within the comms team and alongside, but we've been trying to make sure that we've been giving regular information, regular updates. Our team have been sending out info bursts and just trying to make sure that that information is information that you can trust, and sort of hopefully signposting some of our sort of community groups, patient groups, and patients and public to the right places when they need help. So yeah, that's that. So NHS 111 first, and I'm sorry if you all know this, but it's been really important to us. So throughout the Northwest, there's a new system been introduced called 111 first. What I really need to explain, and what keeps coming up a lot, and if anyone was on our workshop in December that we did, I didn't know if I recognised some faces. There's a real question about, I get asked about, is 111 first different from NHS 111? It's absolutely not. It's the same service, but what they're asking you to do is, if you might have turned up at A&E, and there's a whole myriad of reasons that might be happening at the moment, but if you've not been able to get the help that you need and want, and you think, I'll just turn up at A&E, they're asking if you can ring NHS 111 first. And the reason for that, well, there's quite a few reasons, but obviously during the pandemic, they've been trying to social distance and manage the flow. And 111 can possibly direct you to the best place for you right now. It might not be A&E, for instance. It might be somewhere else, might be better. You might be an out of hours provider that they can get you an appointment with. It might be a pharmacy. 111 also have some protected appointments with GPs. So it might not be that actually A&E is the right place for you. And if you don't need to be there, then it's perhaps better that we're not sending you there. But actually as well, what 111 will do is, should you need A&E, they will be able to book you an arrival time. When we first started, they spoke about appointment times. They have changed that now to arrival times, but hopefully the point of that being that it's less crowded when you get there. They can still keep social distancing, and actually even for you, hopefully it's better that you're not waiting around and you get seen fairly quickly after you've arrived. So yeah, it's so that's NHS 111 first. And like I say, it's really, but it is the same as 111. They're the same service. So should you need, also just to clarify as well, sometimes when we talk, we get a bit of, should I ring 999 or 111? So they do work a little differently in terms of the fact that the 999 is always looking for the emergency, and they will start 999. I think you probably may know, but our first question is the patient breathing? Because for us, 999 is looking for that emergency situation. 111 is slightly different and has pathways built into it, and that's why they ask quite a lot of questions when you ring 111, because they're trying to look for the right pathway. However, should 111 be concerned and think it's an emergency call, they can transfer that over to 999 straight away. So even if you're a little confused, think, oh, I've dialed the wrong one, then 111 have that ability to put it over to 999. The other way, 999 are obviously looking for that emergency. They will categorize the ambulances in terms of how urgent that is. And it may be actually that if it's less urgent, you might get a call back from the paramedics. We have some clinical paramedics that will sit within our control centres that may call you back. So I would just say, don't be confused, just ask us for the help. That's perhaps one of the messages I would like to get out is, please don't, just. And the other thing about 111, and again, it seems a really simple thing, but they are available 24 hours a day, 7 days a week, and online as well. And they are free to use, including from the mobile phone. There are some other ways as well to help improve accessibility, but again, I'll talk about that in a minute or two, I think, in a future slide. So yeah, so this is just some information about some of the extra sort of terms of support in accessing some of our services. So one is the emergency SMS. Now this, if you maybe are deaf or you have barriers to communicating verbally, you can pre-register your mobile number to use emergency SMS. I need to stress, you need to pre-register for this service. So if there's anyone that you think would benefit from them, please ask them to pre-register ahead of time. Sorry, that's Siri just talking to me there. You do need to pre-register for this service. And then once you're pre-registered, should you need to use it, you can send a text message. It sends a text message through to the control room. Ofcom in the last couple of weeks have also brought in some legislation that will also mean that people will have access to a video relay service. The operators have been asked that they have to bring that in within 12 months. That will be a little different because you won't need to pre-register for that. Just like sort of normal 999 call, you will be able to just phone through video relay. But I think the details of that are still being finalised. We've tried to look for some more information, but some of the organisations haven't quite come back to us. So we will keep on that. I think for us, it won't make too much of a difference in terms of, because it's operator-led, the video call will happen there and not with us. So we'll still talk to a person, but it's a real positive there that pre-registering is taken away, because again, not everyone would be aware of that. We also have, if you access 111 first and you need a BSL interpreter, you can use Interpreter Now. So Interpreter Now, like, you don't need to pre-register for that, but you can access them using a smartphone, a laptop or a tablet, and the call can then take place with a BSL interpreter present. Before the pandemic, that service wasn't available 24/7, but it is during the pandemic. They stepped it up to 24 hours, 7 days a week. And we've just done some inquiries actually following one of our sessions about that. And at the moment, NHS England have said there's no plans to change that. So that's a positive for now. But if anything does change, we'll let you know on that one. We also have language lines. So if we need translation in terms of languages, we can access the language line service. This is used in our control room, so it's used in both the emergency and 111 call centres. And again, all we perhaps need to know is the language that the person speaks. So I know we still need a little bit of communication there, but if they can sort of say no English and tell us what language, then we can access the translator. Also, it can be used by our paramedics and our patient transport service on the road, and our patient safety team as well, which is quite sort of important because they deal where concerns have been raised, so we still have that accessibility there. The pictorial handbook is a book that we have out on vehicles. It has some images and picture symbols, and perhaps where there are communication barriers, it can be used. And it should be on all of our vehicles. We're actually just revamping that at the moment and bringing it up to date. And also we have a multilingual phrase book, which again is for where we might need translation, and it's just a book where some of the most common phrases are on it, and we can point across and sort of communicate with our patients that way. So Jenna, I think everyone's probably a bit fed up of me talking by now, so if you'd like to take over this bit.
Yeah, of course I can. Yeah, I'll have to ask you to move the slides, so Deb, I'm sorry. So no, thank you everyone for letting me jump on this today. I think it's really important that we keep talking about how you can get involved in the work that we do. So Debs comes and obviously engages and tells you about what we're actually getting up to, but we actually have a volunteer opportunity for people like yourselves, if you're interested, to help shape our services, to get involved in that. And that's what I predominantly lead on within the patient engagement team. So this is just a quick snippet, it's only a few slides just of what we do within the panel. And if you are interested in some contact details a little bit further down, Debs, can you move to the next slide, please? Thank you. So this is our overall objective for the panel. So it's to work with us at NWAS to influence how we plan and deliver our services to provide the highest quality of care. It's essentially utilising your patient voice. So we obviously regularly engage all the time. Debs and the team do a fantastic job going out and about spreading the word about services and getting that great feedback and experiences. What this essentially is an opportunity for you to get involved in some of our key projects and work streams and really help shape how they're delivered. Because at the end of the day, we've got all this experience around the table, but we actually need to involve patients in that, because you are experts by experience when using our services. So this is an opportunity to get patients, you might have used our services again, you may not have used our services, but just to provide that patient voice in everything that we do. Now, it might be a little bit small on the screen there, but that little circle kind of reflects where the patient and public sit in within, the whole kind of health engagement system and how we want you to get involved. But I'll talk a little bit about that throughout the next slide, if that's okay, Deb, so if you can move it on. So in order to be as inclusive as possible, what was decided was that we wouldn't just have one level of where people would get involved. We would make sure that people could get involved at whatever capacity they have and what suits them best. So because of that, we split it up into 3 different levels that people can pick depending on the time and the background and maybe the work commitments and family life. So the consult level is our lower level of involvement. When I say lower, it's probably the least time consuming. In terms of, we called it our virtual level, but now everything's virtual. So probably have to shift away from that a little bit right now. But it was once our virtual level. So that means, your regular online, getting involved, answering surveys, receiving publications, giving feedback on publications themselves, basically getting involved, but just that virtual element. So that's our consult level. Our co-produce level is our middle level of involvement. It kind of says it on the tin a little bit. So it's essentially co-production, task and finish groups, focus groups. So where we've normally, obviously virtual table now, but get around a table, talk about a key project or initiative, come to a group decision and feed that back. Again, it's very varied in terms of the capacity for that. So it might just be a one-off session that we want your feedback for, or it could be we need your commitment for the next 3 weeks for an hour a week because we want to get this project done in the next 3 weeks. But it is very varied. within that as well, it's not just even the focus group sessions, we do a lot of development sessions as well, so a lot of learning about the trust, because Debs has talked about the core services we've got, but actually there's so much work and teams, and Debs will back me up here, going on in the background, that we just don't shout about. That is so important. So we do a lot of that with that group as well, across all groups, but especially that group. And our influence is our highest level of involvement. When I say highest level, I mean it's the most time that you will give. This level is more for those people who like to get involved in high level meetings, so our committee meetings, our board meetings. We have regular learning forum meetings for each area that we've talked about before. And it's for those people who maybe feel a little bit more comfortable speaking to a large group of people, because as you can imagine, you are actively getting involved in our key meetings that are preset. So it'd be sat around a table with a group of paramedics and staff, and you will be sat on that meeting as well, contributing with staff in the moment that they're discussing the topic. So it is really good and really interactive. Again, my role is to support people in that as well. So if you are a bit apprehensive about that level, that's what I'm there for. I support panel members by joining the sessions with them and talking through and all the acronyms and jargon we talk about. So that's what I'm there for. So that's just a snippet of our levels that we've got, but I hope that kind of makes sense in terms of how inclusive we are, in terms of we don't expect them to all get involved and provide that same level. And at the bottom there, you'll see we've got 157 panel members signed up today, and we've been going since I started in September 2019. So I give myself a little pat on the back for that, seeing as we've been in a global pandemic. So yeah, but obviously we want to get as many people as we can involved as well. Thanks, Des. If you can move on to the next slide, please. So again, this is just a little bit of a snippet of what we've got involved in today. Now, there's much more that we've got involved in, but this is just a little bit of an idea of what we've done. So we're currently helping, Deb's mentioned about the pictorial handbook at the last slide. We're helping to revamp that and make it more inclusive, more accessible, a bit more digital, keeping up with the modern times, which will help our paramedics as well and patients. So we're helping to revamp that. You'll see this in the background here, our screens, the high. Our panel members helped to revamp our brand and make it a little bit more friendly, so that was great. We've worked, NHS England have heard about us and wanted to utilise the panel, and we've actually helped to work on the non-emergency patient transport service eligibility criteria, which has now been fed into a wider review. I mentioned earlier with regular attendance at learning forums. Deb's again mentioned the 111 initiative, 111 First initiative, and we actually helped co-produce ideas around that and how we convey the messages to the public. We've got a lot of people with lived experience on the panel who provide great updates and key insight at our specialist meetings. So, for example, our mental health and suicide prevention meetings, they've been really well received. And I think a fun one that I wanted to highlight, because obviously a lot of the time we've been engaging has been virtual right now, so it's been really difficult. But actually last year when things started to calm down a little bit with COVID, I know it kind of ramped up again, but we had a mystery shopper activity. Well, we call it a mystery patient activity, and it's where panel members volunteered to take a fake taxi journey with one of our third-party provider taxis who provide patient transport to assess, actually, are they doing the job right? Are you treating patients with respect and dignity? Are they wearing the masks? Are they putting hand gel on? Are they guiding them to the hospital appointments? So that was a really, really good opportunity and quite interactive, because as you can imagine, we haven't been able to because of the pandemic. That was really good. But that's just a snippet of what we've done so far. And also, I've got the big one in the middle, 100. I don't know how I've missed that. So in the first year, we got 100 panel members, which is quite successful. So I'll put that in the middle. Next slide, please, Debs. This is just our contact details, essentially. So this is our little team there. So you see myself, Jenna, I've got an administrator, Francesca, and you'll notice Sean there at the bottom. Sean is Francesca's guide dog. So if you do ever get involved in the panel or engage with us and see us face to face, you'll probably end up meeting Sean, who is a delight, may I add. So that is our little team. Our email's on there, but I'm guessing, Debs, are we going to be sharing the slides with, yeah, so you'll get this information via Debs in the format of the slides. We've also got a Twitter account. If you do want to see what we're getting up to in the panel, please feel free to follow us on Twitter. But if anyone's got any questions, I'm happy to take them now. If not, please get in touch if you're interested, and I'm more than happy to have a conversation with anyone about the panel. But that's it from me, just a little snippet. Thanks, Debs. Deb's on mute.
Sorry, I couldn't get myself off mute there. I couldn't get the screen at the top. Just before I move on, I have got a few more, but I can see Diane's got a hand up. So I just wondered if Diane has a question for Jenna. Yeah. Apologies if anyone else has, but I can only see Diane's hand at the moment.
Right, brilliant presentation. Really impressed with that, firstly. The issue we seem to have here in Halton is that people can't get appointments with GPs. So then they're told to go to the urgent treatment centre. They get down to they phone up the urgent treatment centre. They're then told they haven't got any appointments, and they're getting told to go to A&E. And the other thing is people phoning 111 wait for ages for a reply from them, because they get told somebody will ring them back, and unfortunately it can take hours for them to get back. So this isn't the problem of the ambulance service, it's a problem of the whole system at the moment. And it must be so frustrating for you in the ambulance service when somebody phones up and says, I need an ambulance now to take me to A&E, when really they don't.
I think absolutely it is. And I think from what we're hearing, as much as like I said to you before, I would always want people to ring us if they think they need help in any way. I think nationally that's a frustration at the moment. Our colleagues are telling us that there is frustration about those lack of resources, and you know, our staff are quite sort of, they've been working through the pandemic for a long time now. So it's that thing of trying to make sure that people are calling us for the right reasons. But I can also understand that people aren't perhaps accessing the help that perhaps they should be elsewhere, so they don't know where else to turn. So I think it's, for us, it's about constantly sort of sharing those messages of how we can help. From our side, we will constantly be looking at the resources we have, what we can do to support that, what we can do with the messaging, and how we can best serve it. But yeah, I think it's a really valid point. So yeah, I did have just a tiny bit more of the presentation, and it's fine, but it was just about some ways that you can help us as well. So we have been asking people really some simple things, but what 3 words, we are now using that within our control room. So if you do have the app and you sort of need to give us your location, I think everyone thinks we've got really sort of good tracking systems, and they're perhaps not as good as everyone thinks. So what 3 words is a really good way to help us. And also, can we see your house number? Now, perhaps less so now when it's the light nights, but certainly during the winter, that's a big one for us. So can we see your house number? Is there a light on? Especially some of the more rural areas where a postcode can cover 5, 6, 7 different houses. It's quite important for us. And some of what I think Diane perhaps just referred to as well about those weights and things like that, we always want to know how we're doing. So we do have lots of opportunities for people to share that experience. It's what we learn from. So we obviously have our patient safety team if it's a complaint or a concern. We'd love to hear compliments, I think, as well. And also on our website, there are surveys which our team are responsible for. We do ask the friends and family test. So you may get text messages from us asking you that, but also should you want to just share something with us, then there are surveys on our website, or there are emails to contact our team as well. And we always like to hear from you. So that kind of is the presentation. I've talked a lot, so I've got 2 things to ask you now. One would be any questions for me and Jenna. And secondly, has anyone got any experiences they'd like to share with us and that we can perhaps take back? Jenna will be taking some notes, I think. So yeah, and thank you everyone for listening. I hope it's been okay.
Thank you so much, Deborah and Jenna. That was absolutely brilliant. And thank you everyone for listening. Like Deborah said, if you've got any questions, just pop your hands up and we'll come to you.
Right, I've got one, Jude. Just
thank you, Dave.
If I can leap in.
Go ahead.
On the language line, just on, because we did have a call from one of the groups that supports the asylum seekers. Now, there'd been a family who tried to ring NHS 111, but having very little English at all. When we rang NHS 111, you get given the options at the beginning. Well, obviously within English, and they couldn't understand those. And I think we'd also asked the volunteer to try it, and it's quite a way in before you get the option of, I don't speak English. Is the translator available? Now I know they've got the NHS 111 option 2, which is the mental health crisis line. Is there any consideration about trying to make it easier for people who don't have English as first language, but maybe you could have a NHS 111 press option 3, which could be or 4 or whatever it happened to be, which could be promoted across various networks, so it was a quite straightforward thing to do.
So Dave, I'm going to hold my hands up there and say it's not something that I'm aware of, but I think that is a really, really excellent piece of feedback that we can take back to 111 and ask them to consider that. So absolutely, we will be feeding that back after today. So I'll let you know if anything changes on that. But like I say, I'm not aware of those plans, but I think we'll feed that back and see if there is anything there that we're aware of. I know we review it constantly, but maybe our focus has been more so on what happens when you access it rather than that beginning bit. And actually, if you're not accessing it in the first place, because that's too difficult, that's a really valid point for us. So we'll take that back.
Thank you.
Thank you very much.
I think the family involved also spoke a particular dialect. They were from Syria, but they also didn't read their own language. They only spoke, so it would be difficult there. They did rely on the volunteers, but when the volunteers tried to go through it, I think they said it was press option 1, press this, press that, and it was about 5 presses in until they got the do you want to speak to do you need a translator. Just on a slight follow-up from Diane's one before I can see Colin's got his hand up. We've got, how up to date is the information you received from the local services like the urgent treatment centres as to their availability? Because again, we had somebody ring us last week, I think it was, who had tried I think they'd rung NHS 111 and they'd referred them on to the urgent treatment centres. They spoke to one of the urgent treatment centres who said, we're only triaging today, we can't actually see you. Go to the other urgent treatment centre in Halton. They went to the other one and said, we haven't got any doctors on today, so you can't come to, you'll have to go to A&E. So you can see there, but I wondered how up to date that the urgent treatment centres, for instance, keep you informed on their staffing situation.
So my understanding was that we should be very aware of it. We use a updated directory of services that's always being updated and what have you. But obviously in that case, it sounds like it's not happened. So again, I think I'll ask Vicky, our colleague in 111, for a definitive answer on that, because I don't want to fudge it for you. I don't want to say. So whether it's just been a breakdown of communication there, because for instance, when I talk about GP appointments that they've got ring fenced, my understanding there was they could absolutely see that availability, and if they haven't got it, they won't direct you there, for instance. It just won't be available. And my understanding would have been that was similar for sort of the other places, but we'll take that back and I'll get a definitive answer for you on that one.
Colin, over to you.
Yes, thank you. It's probably like everybody else in the country. When I watch the news and I see that our ambulance service, our staff, paramedics are being attacked by, I don't know how to describe the people who attack paramedics. So you're recording it, so I won't use the words that I really use when I'm watching the television. But these people who attack them, what can be done? I probably can't answer this question, but something obviously needs to be done to protect our paramedics and excellent staff from these people. I mean, is there something, do you call, I mean, obviously probably you call the police. By the time you call the police, the paramedics have already been attacked. Is there some sort of strategic plan that you go into particular areas that you know is quite dangerous, and because they have to be protected, and these people have to be dealt with? I know that's a bigger issue, involves government agencies and so forth, but I'd like to see our paramedics protected more.
Well, as a first step from our side on that, I think I don't know if it's a first step as such, but one of the steps we're currently involved in is we're involved in the body worn camera pilot. And in all of the areas that we cover, we have paramedics now trialing the body worn cameras. So they don't record all the time, but if a paramedic feels threatened in any way, they can press the button on their camera, and they would obviously advise that they're doing that, but that will record whatever's happened. Now, I know that doesn't necessarily protect them as such, but some people would back off from there and also we then have the evidence to support us should we prosecute afterwards. We do have some markers on addresses when you said about going into areas. So if we've been to, for instance, an address before, it may be that there's a violence and aggression marker on that address. And if we know, then we may stand off and wait and request police backup basically and wait for that. We do also have someone within the trust who is our violence and aggression lead, and they are responsible for looking at this in particular and how we protect our staff, how we support them after as well, because that's a really big thing. Not only supporting sort of after the incident, but should it go towards court that we prosecute, and we will try to, wherever possible, we will try to prosecute to get that message out that it's not acceptable and what have you. But I think all of them are starting points, and we do just need to continue. And like you've said, there is more that needs to be done to protect our staff. But I think it would be interesting to see what the pilot brings back as well. And like I say, it's constantly, we have a lead in the trust for that. So it's definitely a priority for us. And he's fairly new in the trust. And I think, so hopefully as his role progresses, it'll be interesting to see how he develops that. So I hope that answers it in a...
It does. I just want to see them all protected. That's it. Because you do a wonderful job.
Thank you. Wonderful. As do we definitely want to see them protected.
Thanks very much. Thank you. Thanks. Excellent presentation. Thank you.
I can't see any other hands up. I've got another question, actually. If it's okay. Partly it is that anything we can do as Healthwatch to help in the work that you're doing. It might be aimed at Jenna, this particularly around the patient participation. One, certainly if you want to send us the information over, we'll give it. Jude can promote it online. But if there's any particular pieces of work, I mean, I know as you mentioned, the patient transport service isn't covering most of Halton. I think it will cover Hale, because Hale Village has a Liverpool postcode. The rest of Halton has Cheshire postcode. But while I've talked now, I've encouraged Paul and Diane to stick their hands up. Go to Paul first, if that's okay.
Yes, thanks, Dave. Excellent presentations. Thank you very much. Each time I come to a presentation, I learn a lot more. This question might be a bit controversial, and I'm quite happy for you to say I don't want to answer that question. But the Manchester Arena incident keeps coming up on the news, and I wondered what the ambulance's viewpoint on what happened, because you get strange stories coming out of it. I wonder if you could comment on it. If you don't want to, that's fine, but I was just interested.
Well, so it's less of a don't want to, but more of a I can't at the moment. At the moment, we're not allowed to comment on it because of the fact the inquiry is still taking place. So we can't comment at the moment. I'm sure we will be, but we have to wait for those legal proceedings to be over. So please don't think, but at the moment we can't. So I'm really sorry on that one. But like I say, just while it's still going on and what have you, we're unable to comment on that one. So yeah, that's but thank you.
Yeah, that's fine. I hope you get the chance to comment, because I think sometimes you don't get the story till right at the very end of things. But thanks again anyway.
Diane?
Hi, yes, this is a completely different one. This is, you see on the television, the poor ambulances queuing up outside A&E departments. They've got the patient either in the back or half in the back. They don't know whether they've got a medic going in to see them. And obviously, while this is all happening, you can't be back out picking anybody else up. So this, has anybody thought, I know this may seem simplification, of having specific people in A&E, and that is their job, is to go out to assess the people in the ambulances and to then triage them there, not waiting till they get inside the hospital. It may just not be unfeasible, but so they could get you back out on the road again to do the job you're expert at.
So it's actually not that's a really, really good idea. And actually Jenna might know more about this than I do because her panel members have been involved in it. But we have something at the moment called the Every Minute Matters project, and it's being run by staff within our organisation, and they're working with, it was 12, it might be 14 or more different hospitals across the Northwest, and it's exactly on that. It's about that handover and how they improve the flow to the hospital so we can get the ambulances back out on the road. And different hospitals are doing different things. So some of the hospitals are doing exactly that they might actually have some of their staff triaging, or I know in some hospitals that we've put staff in that perhaps would take responsibility for, say, 2 or 3 patients or 3 or 4 patients if they're well, if we think they can reasonably be left. We always, they are our responsibility till we have handed them over. So while they're in the back of our vehicle, while we're stood in that corridor, they're our responsibility. So we're always going to be very careful about that. That's, you know, from a safety perspective. But Jenna, you've been involved in some of that, your panel members have been involved. Is there a bit more you could add to that? Sorry, is there anything I've missed?
No, you're 100% right. So they're working with different hospitals across the Northwest and obviously learning from each collaborative that they're doing. So for example, Deb's mentioned that there's different teams in certain hospitals. I know one hospital, I think it's Blackburn, they've got like a handover checklist in place now where the paramedics would complete a handover checklist. If they felt that they were appropriate to be left in A&E on their own, in the waiting room, then they could get left over. So there's different things that different hospitals are doing. The next collaborative from the next cohort of hospitals was supposed to start, I think, now, but because obviously of our high demand at the moment and stuff, we've just not been able to. Also on the flip side, a little bit from our end as well, Diane, really about our paramedics. So we've done a lot of work with our senior paramedic team leaders and panel members about right care at home, encouraging paramedics, actually, if patients don't need to go to hospital, we shouldn't be conveying them. So it's building that confidence in our paramedics to actually signpost patients to different services in the community. So there's been a big push on that in terms of that right care at home and trying to stop patients from going to hospital if they don't need to go, really. So there's lots of different work going on within the trust. There's even something coming up, as again, I don't want to spoil it if you are interested in joining the panel, but a little bit about you know, alternative transport for patients. So actually, I didn't know this, and I've learned something new, that actually we can come, I mean, correct me if I'm wrong, Debs, because I've not been here as long as you, but if we come to your house in a 999 vehicle ambulance, if we think that you can get to hospital on your own and don't need us to convey you, we can say to you, can you get yourself to A&E on your own and take yourself there? But again, that's all about building confidence in our staff to say that, you know, and say, actually, you can take yourself to hospital because you don't need an ambulance right now. There's people out there who need ambulances more than yourself. Obviously, that depends if they're quite low acuity calls. But there's a lot that we're doing, And it's all about that public messaging as well, Diane, you know. There's a lot going on, but yeah, the big ones, the Every Minute Matters, I would say. And if you do get involved in the panel, if anyone's interested, there'll be information circulated around that and hopefully more opportunities to get involved in that piece of work. So a big piece of work though, Diane, as you can imagine. Hope that makes sense. I hope I didn't say anything wrong there, Debs, about the alternative transport. Good. Thank you.
Thank you very much.
Has anyone else got any more questions? I've just got one, but I'll let anyone else go first if they've got anything else to ask. No. Just what you're saying, that there's alternative ways to get to A&E. Is it always the best idea to call an ambulance, or if you're able to, like you say, would you be better to drive yourself or a family member that might be injured or in need of help? Would the ambulances get priority, or would it be just as well to drive yourself to A&E?
That's a really good question, Jude. So my first answer to that would be, if you think it's an emergency situation, you should be ringing 999, and that's why you should be ringing us. So, you know, I would never ever not say that. You absolutely, if it's an emergency situation, you should be ringing 999 without fail, and we will triage it. Now, there is actually a situation where, when we are really, really busy, if we've prioritized it as a lower acuity call, we might say to you, we are going to be, we never give times. I think perhaps, I don't know if anyone's aware of that, but we will never ever give you a time to say will be 5 minutes, will be half an hour, because we just can't do that. We don't know what might happen in terms of other calls coming through, of higher sort of priority and what have you. But like I say, when we are really busy at the moment, we may say to you, we are really, really busy, we may not be with you for a little while. Is there a safe way you can get that person to hospital? So in that case, we might ask you to consider that. I think there's also that separate thing for me about, like when we were saying before about the fact to call in 111 and getting you to the right place as well. So I think I'd never really just tell someone to put you in the car and take you to A&E. I think we've got those provisions there that we are trying to help with. The ambulances do not get priority. And I think that's a big thing that we have to highlight. It's a real myth that people think going in an ambulance will see you quicker. That's not the case at all. And actually, Jenna mentioned that hospital handover checklist. We will just as easily put you in the waiting room if that's where you need to be sat, because you're not so much of an emergency, and you will be triaged with everyone else. So it's a real myth that going in an ambulance will get you there quicker. But like I say, at the same, on the other side of the coin, we are the emergency service and we are there for you in an emergency. But yeah, you won't be seen quicker just because you've gone with us. We'll, you know, there is obviously, if we take you in and we're taking you straight into resus because you are that much of an emergency, but that will be triaged and what have you. But yeah, if you're calling us for something that's less because you think you're going to get seen quicker, then we've got no qualms about putting you in the hospital reception and you being triaged with others. So yeah, a really good question and a really good myth that comes up so much about.
Thank you. Yeah, I know when we've done when we've done outreach in the past, when we were allowed out and about in A&E, I know that we have met some patients who must have been lower priority, who come in an ambulance and then they were in the waiting room with everyone else. Yes, thank you for answering that. Just one more question from me, and then we've got a question from Colin as well. Just, do you work with GPs at all? Does your patient panel meet with them or anything? Just because sometimes we find patients who've really been going around in a circle, and sometimes it's quite worrying because it sounds quite serious what they've got. So, for example, we had a gentleman last week. He's gone to his GP, there were no appointments left. They've advised him to call NHS 111, which he's done. And so another GP has called him back at 3 a.m. and then suggested he goes back to his GP. So he kind of just kept going round and round in a circle until he found us. And he was really unable to get an appointment from anyone. So he was kind of left with going to A&E, but he didn't want to bother them, and although it sounded quite serious, you wouldn't have called 999 or anything. So he kind of was being sent from one to the other, and he was you know, really frustrated. He didn't know what to do, and that's how we ended up speaking to ourselves. That's a really difficult situation. We would talk to GPs, and I know those conversations would go on like at a strategic level, and the same when I mentioned pathways, for instance, if they're not right, they can, you know, we do get feedback on them. The panel less so. I think that's a different question, because a lot of GPs tend to have their own patient panel groups, and we've not really sort of brought those together in any way. But in terms of 111 and those conversations, that will be happening. So I feel really sorry for that, gentlemen.
maybe that's something that can be shared and we can look into that in a bit more.
I could write up a story anonymously and send it to you. So you've got all the details. That would be. It just sometimes people do seem to be getting sent round from one to the other, and it's quite frustrating and possibly even dangerous for them in the end.
Definitely. I'm just checking the chat whether that was a question. No, Tracy's going. Thank you, Tracy.
Colin has got his hand up as well.
Hey, Colin, thank you.
Yeah, sorry, it's more a statement rather than a question. It's just sort of something that happened to me. I mean, obviously, if somebody takes a heart attack or takes a stroke, sorry, I know you said you no clinical training, but that's obvious. That obviously needs an ambulance. That's an emergency. But there are some grey areas. I mean, my one particular case was being at the optician or optometrist, I believe they call it these days, told me, examined my eyes and told me immediately to go to A&E. And I was fairly relaxed about it. In fact, I went shopping afterwards and got magazines and everything like that. And I drove to A&E. I wasn't going to call an ambulance. I drove to A&E and saw the doctor amazingly quickly. And the first thing I said to the doctor was, I'm wasting your time, but I've been told to come here. At which point he said to me, examine my eyes. And they looked at me and he said, you could go blind now. And so there are some, as I say, I know you're not clinical, but there are some situations where it's another example is I have a condition which I won't go into in detail, which can start off with fairly obvious signs, which I would not consider calling an ambulance, but it certainly needs medical assistance. So I would certainly plan to drive to A&E or whatever advice I get from 111 first. But that condition can get it can worsen extremely quickly. What I'm trying to say is, if I called an ambulance, they'd say, oh no, you're okay, you can drive. They could drive off and within 5 minutes, the situation can change extremely quickly. So I'm just saying sometimes it's very difficult to know exactly what to do. And I know what you said, phone 111, but you know, if I phone 111, if this condition kicks in, which it can do, unfortunately, by the time they've answered my question, I could be in serious trouble. You know, I'm not trying to make this difficult, and I know it's more a statement than a question for you. But the patient, you must remember, I'm not clinical either. So people, the members of the public, have to make a decision. Obviously, if they have a heart attack, bad chest pains, collapse, that's blatantly obvious. But some serious conditions are not initially blatantly obvious. And it's very difficult for the member of the public, to know what to do. As I said, I was sitting in front of the consultant, well, not the consultant, the doctor, apologizing for wasting his time. And he looked at me as, you know, that look you get from some doctors, like, this person has no brain in his head. You know that look you sometimes get. And, or is it only me that gets that look? Maybe it's only me that gets that look. And so I'm just saying, it's very difficult for a person to know. Well, I suppose let's ask the question then, rather. I mean, could 111 answer that? If I said, this is my condition, I won't bore everybody with the details. Would they be able to, because I know the person on the other line isn't clinical either, I assume they're not.
Yeah, most of them aren't when you first phone.
All I'm saying is, you know, I could get the wrong advice there.
Yeah, I think there's a couple of things for me in that. You're not the only ones who have had that look from a consultant. I actually, or a doctor, I phoned 111 with a pain in my side that got progressively worse. And they said to me, they were like, go straight to A&E, we'll send you an ambulance. I was like, no, I've dealt with it all day. I live 10 minutes away from the hospital, a bit like you. I'll take my time, I'll drive myself in. And it was a pulmonary embolism. So yeah, I've been there. So I've had that look. So I get that. I think there are a couple of things for me in terms of your condition. You are the expert on that, like you say, and we're not. And I think I wouldn't put anyone off in your situation or a similar situation just doing what they need to do. I think for me, the message around 111 first is some of those people that perhaps would turn up for perhaps those lesser things that perhaps they don't need to, and what have you. So I'm always at pains to say we are there to help. I would never put anyone off. And actually, even A&E, they're not going to turn you away because you've turned up. If they think it's inappropriate, they might redirect you to what to do next time, if that makes sense. But again, if you've turned up with your condition, that's not inappropriate use, and they're not going to. But it's more so, for me, it's that messaging around, if it's slightly sort of inappropriate, they might, and like I say, they won't turn you away. They might have just said to you, actually, was this the best way? Perhaps next time you could consider this. So I think it's a really valid point, and there's always going to be certain areas. In terms of 111, my understanding is that they have to follow those pathways to a certain level, and I don't know with the condition. I'll check it with Vicky, that they can just automatically jump to that, because I think they're following the symptoms and what have you. So, but like I say, you are the expert with that experience. You know your condition, you know the body, and you know what might be. I've got similar. So I'm quite immunosuppressed and what have you. So a bit like you, certain eye conditions, for instance, for me, could become really important really quickly. So it's that type of thing that if you know that, then perhaps you go looking for that help. You know, you would go looking for that help. So I completely understand. But yeah, I think for me, it's about that message where perhaps it might be an appropriate use of turning up at A&E, is where we need to target that message more so, if that makes sense. But like I say, you would still get help. It might just be that they would just sort of suggest that next time there might, if it had been inappropriate, which it certainly wouldn't have been, that there might be an alternative in the future. So yeah, so that's the main message. Make sure everyone still accesses help when they need it.
I think I'm actually the other way. I'll probably die first. You know, I'm sort of, I don't want to waste the ambulance time.
No.
So I'll hang on and hang on. And so, I'll hang on too long.
Yeah, you know, and that's a lot of people do. They're actually perhaps in a, I don't want to say worse condition, but they've waited until their condition's worsened before they've called us because they don't want to. So I think that is why I'd always encourage anyone to seek assistance. And if they're unsure, 111 are there for you in the first place, preferably before it becomes an emergency situation. So I completely understand that, Colin, because I'm the same. I absolutely will wait, sort of thing. So yeah, completely understand that. Thank you.
Thank you. Thank you.
Nikki, you've got your hand up.
Sorry, my mouse was going a bit funny. I couldn't get myself off mute. I think that's one of the things, isn't it? I think as much as you're going to get people that rock up to A&E where actually they could have gone elsewhere, I think we can be really bad at kind of sharing the information when we need to be sharing it. And I think it's that assumption that our records, because it's on the computer, that our records are there. I had it myself once. I went to the walk-in centre because my breathing just went, I couldn't explain it, but my breathing was just so strange. And I got triaged at the walk-in centre, and he was like, as I was literally about to leave the triage room and sit back down in the waiting room, I said, does it say on there that I've had a DVT? And she said, it doesn't. No, she said, you are now next to be seen. So it's about sharing, making sure that we're giving the full pictures, because we can only be triaged with what we're actually sharing as well. So I think it's, again, like Colin, it's a bit more of a statement rather than a question, but it's kind of encouraging people to share everything, even if you think it's not relevant.
No, that's really valid, because actually when you phone us, for instance, certainly as an emergency call, we don't have your history. We're starting with what's in front of us now. Now that is starting to get a little better. There are things coming in. For instance, we're now doing electronic patient record forms, which we've only just introduced within the trust. So things like that we can now perhaps send over to the hospital, and we can see certain things. But before we're almost blind until you tell us that you have that condition or whatever. We don't particularly know. Again, there's other projects that are going on to look at this, medical markers and what have you. So some we do. There are some conditions that are highlighted with us. We do have some markers, but they are address-based as well. And they're put on by a healthcare professional. So some people we will know before we go, but others we are starting from that complete place of, you know, I want to say ignorance, but a starting point of not being aware of that. So I, like you, have had a DVT and PE in the past, so would be at higher risk, you know, that type of thing. Yeah. But people looking at me aren't going to know that, you know, and if I can't express that, then it absolutely has to be something that we say. So I think that's such a valid point. Like you say, we are starting to make improvements on that. And again, we've got systems, you know, if I've been doing this 12 months ago, even, we've got 3 or 4 different systems that don't talk to each other. We're now moving to where they do, so that's a better process that they can see some of that, but we're not quite there yet. So I think that's really valid, that we need to know if there are sort of conditions or something that we need to know. And, you know, don't be afraid to tell us, you're the experts in your condition, you know, sort of thing. So really, and I know, you know, the paramedics come, for instance, and they're in green, and there's that trust in the uniform. There absolutely is, and I get that, but you're also the person living with your condition day in, day out, and you know what's important to you. For instance, you know, if you're a COPD sufferer, you might know what your normal stats are, and they might be different to what our normal benchmarks are. So it's things like that. If you can absolutely tell us, then please do so, because, you know, that really helps us. So thank you so much. That's a really, really valid point, Nikki. Thank you. Is there anything else? I can talk a lot, as you might have noticed, and I think we have gone over time slightly, I think, but I'm still happy to answer any questions. I'm fine. But other than that, like I say, I noticed we've gone over slightly, so sorry for keeping you.
Oh no, that's
Is there
fine.
any more questions, anyone, before we go? No. Do you want me to just remind of the next chat, Dave?
Oh yes, very quickly, please. Yeah.
Okay, so our next Tuesday chat is actually on a Monday, just to keep you on your toes. It's 2 nurses from Cancer Research UK are going to be given a cancer awareness talk, and that is the 2nd of August.
Oh, Jude's frozen. 2nd of August. Technology worked quite well up till then. But, yeah, so just to round up, thank you all for attending. Thank you for, again, a wonderful presentation. And certainly if there's anything we can do to help, if you need us to promote anything, or you'd like us to get involved in anything around any work at, you know, Cover and Halton, please let me know. We're more than willing to help on that. All enjoy the rest of your day. I've got a managers meeting to look forward to at 2 o'clock.
Nice. Thank you, everyone. Thank you for being so involved. It's been lovely to speak to you. Thank you.
That's it. We left Jude back in, but we'll cut it out now. Okay. Enjoy the rest of your day. Take care now.
Thank you.
Bye-bye.
See you later.
Can I just chip in saying I've got some well, they are public sessions, like sessions for organisations, mental health awareness and suicide awareness. If anyone's got any staff that needs to go on that, I have got them in August, and there is still a couple of places. I have sent it out on my mailing list. I think you're on my mailing list, Dave, just in case there's anybody in here that's not on my mailing list.
We are, yes, and we may send a few people along to you.
Fab.
Okay, thank you.
Thank
Nikki.
you.
Okay, take care. Bye-bye.
See you, bye.
Bye.